So this is our afternoon plenary, and I just wanted to welcome you. My name is Erin Athey, and I am a nurse practitioner here in Washington, D.C. Disclaimer, I am not Erin Myers, who is the amazing machine behind this conference, so just to be clear on that. I'm a nurse practitioner here in Washington, D.C., and an ANAC member, and also faculty in the nursing school at GW. I'm also the co-chair of this conference and an outgoing board member. So really glad to have you here. Is anyone new to DC? Is this the first time for anyone? Okay, awesome. Well, welcome. Who's here from the DMV? Who are the local people? Okay, great. We'll look at those people and see who they are, and you can ask them for directions because I still don't know my way around the city. No, welcome. So I am just going to give a couple of reminders. I have my mask off up here because we're distancing, but everyone so far I've seen is doing an amazing job of keeping masks on, except when you're eating and drinking. We are, up here spacing out, and we're removing our masks, like I just said. So just keep that going, and if anyone has any questions, please find any of us, and we will answer them. I am now going to introduce our next speaker. Her name is Jennifer Cates, and she is the Senior Vice President and Director of Global Health and HIV Policy at KFF, formerly known as the Kaiser Family Foundation. This is where she oversees policy analysis and research focused on the U.S. government's role in global health and on the global and domestic HIV epidemics. Dr. Cates has served on numerous high-level federal and private sector advisory committees on global health and HIV issues. Her full bio is very impressive and is on the conference app. So I invite you to view that. But please join me in welcoming Dr. Jen Cates now.
Thank you so much. Hi, everyone. It's great to be here. This is my first in-person presentation, so for 2 years or so. So great. You're the first audience. Bear with me. But anyway, I wanted to start by saying when Carol first approached me to talk about this, she emailed back in June and said, will you speak about the global epidemic, HIV epidemic, and the impact of COVID? I really didn't know what I was going to say because so much changes so quickly, and I didn't know what the story would be. And actually a lot more information has become available since we had that initial talk, and the story is a little different than I expected, in some ways better, in other ways maybe not. So I will share with you what I think it was important to know about whether or how far COVID has set us back. And this is really at the global level, so not what's happening in the United States, but I think it applies to some extent here as well. So I'm going to talk about 5 different things. One is the pandemic, the COVID pandemic's global impact, its potential impact on HIV. So what I thought in June, how I would, what I might be expected to see, and what we know now, the reported impact, the role of COVID-19 vaccination and other mitigation measures on the future trajectory of the HIV epidemic, and then lessons from HIV for COVID and looking ahead. So just to start, I just show this on a lot of talks I give on COVID because it's so obvious now, but I don't think everyone pre-COVID really thought as much as we all do now about how interconnected we are and how quickly everything spreads around the world, whether it's information, viruses, people. So it's just, to me, it's the perfect illustration. And we know, because we all have been living through this, that COVID has resulted in a massive global disruption that we've not experienced in modern times, truly. And so some of the ways, not that these will be surprises to all of you, but I think it's us setting the scene to remind us how significant the disruptions have been. The global economy has contracted from this pandemic. Education has been disrupted all over the world. Trade and travel. This is probably the first time many of us have traveled, or many of you have traveled. Supply chains, we can't get things that are just basic necessities for home, but also supplies that are life-saving. The number of people living in extreme poverty has gone up significantly because of COVID. The labor market has been impacted. People are isolated, populations have been displaced, and there's global food insecurity. And I could go on and on, but it's just important, I think, to try to capture how significant this is. And then, of course, there's the direct and indirect health impacts of COVID-19 itself. Just to show you some data, since that's what we do at KFF, for those of you who know us, we love data. This is showing a very long trajectory of the GDP, and you can see here the dips. COVID-19 has resulted in the worst recession since the end of World War II. That's a very dramatic impact that most of us have not lived through or experienced in certainly our adult lifetimes. This, to give you a closer view, this is GDP drop in 2020. It's going back up, and it's certainly going back up in high-income countries, but this was a significant dip that we all lived through and should not be a surprise to any of us. Here's some data on what's happened to the number of people living in extreme poverty, which is defined as living on less than $1.90 per day. That number has been going down thanks to lots of different efforts, and you can see because of COVID, it started to go back up again, and even the best sort of scenarios are not good. Part of the reason this is happening is because of what has happened, frankly, in the labor market. People are working less hours, and that translates into millions of jobs that have been lost worldwide. And some of these impacts are probably going to be long-lasting. This is some data from looking at sub-Saharan Africa, which is estimated to have permanent economic effects or a permanent drop in real income because of COVID-19. And all of these dramatic impacts that affect our lives have real impact on HIV services and the people that we are trying to reach globally who are at risk and living with HIV. Going to sort of data on COVID itself, here's a snapshot of the global COVID toll so far. This is from a couple of days ago, so I assume we're about 250 million cases have been reported globally, over 5 million deaths, and there's somewhere between 6,000 and 7,000 deaths a day still. And you can see this is another look at deaths per day and how high they still are. One of the things that I think is important to acknowledge about COVID's impact, and this has bearing on HIV too, is that it's not just the directly measured COVID deaths that we know have occurred. It's the deaths that were due to COVID that weren't measured, that weren't reported, sometimes because in certain environments or countries where surveillance systems aren't as good, or people die of different things and it might not be recorded. But also there's other deaths that would not have occurred if we weren't in this pandemic. People who couldn't get services that they needed, people who couldn't get food that they needed, people who lost their job, their livelihood, were isolated. So these are graphs of excess mortality in many different countries, and it's pretty significant. The other way that COVID-19 has had a dramatic impact in a very short time is on life expectancy. It has resulted in a dip in life expectancy in many countries, including the United States. You can see here that the US has actually lagged behind most peer countries in life expectancy, but took a real dip in 2020. One of the only other phenomenons like this that I'm aware of happening in the last 50 plus years is HIV. This is a graph of what was happening to life expectancy in sub-Saharan Africa before the introduction of antiretrovirals. And I remember when this came out thinking that I studied demography in grad school, and when you study demography, you learn that very tiny movements in life expectancy are the result of big things. So to see this impact from HIV at the time was incredibly dramatic, and happily, we know that was reversed because of PEPFAR and many other efforts. But we're just to remind us that we've seen this before, and now we're all experiencing it because of COVID. So with that broad picture in mind, what are the potential impacts on the HIV response? And back in the beginning of 2020, when COVID-19 was pretty clear it was becoming a pandemic. First, everyone thought it was outside of the US, but there was a lot of concern among those of us working globally on HIV, as well as I'm sure anyone here working globally or domestically on HIV, what would it mean for people at risk and people living with HIV? So various models were developed to look at this, and here are the potential negative direct impacts that were identified. First of all, we know, and maybe you've heard about it already at the conference, that there does appear to be an interaction between COVID-19 disease and HIV. People with HIV who become infected with SARS-CoV-2 and have COVID disease are more likely to develop severe illness, more likely to die. There's lots of reasons for that, but there's a direct relationship between the two that's important and has bearing on the potential impact. Also, and a big one, and I think the one that we were all most concerned about initially, was the potential interruption of ARVs. What if people couldn't get their treatment? What if their treatment got interrupted? That could be incredibly devastating personally and for the epidemic. Suspension of HIV testing. What if testing was unavailable? Healthcare worker shortages, whether it was nurses, doctors, lab technicians, a big area that could really have dramatic impacts. Lack of condoms and other commodities that are critical to particularly prevention for people at risk. Suspension of voluntary medical male circumcision in countries where that's an important intervention. Suspension of prevention of mother-to-child transmission interventions as well. Lab interruptions, so if viral loads or CD4s could not be carried out because labs were unavailable, or closed down, that could have implications for monitoring treatment, for starting treatment, for all the things that we know. Suspension of PrEP. So these were the hypothesized ways, I mean, not that they all have been affected, I'll tell you that, but these are the hypothesized ways that many people looking at this back in the spring of 2020 thought could have an impact on the trajectory of the global HIV pandemic. And some modelers actually looked at what it would mean if these things occurred, if there were interruptions in these areas. They looked across many models, and they found big effects of service disruptions on mortality in sub-Saharan Africa. And you might have seen these studies when they came out, but they basically predicted that a 6-month interruption of antiretroviral treatment for about half of the population who needs it would result in a median of almost 300,000 additional deaths just in a year. And that was more if the interruption was greater, it was less if it was not as severe, but it basically showed that this could be a dramatic impact. And it really, I think, put a spotlight on the need to maintain treatment. The modelers also looked at all of the other areas, most of the ones I highlighted, and also found effects. They were not as significant as what it would mean to have antiretroviral treatment interrupted. Here's some of those results on ART treatment disruptions. They looked at, as I mentioned, 5 models, and they looked at different shares, and in all of them you can see these are the number of deaths predicted if there was a 20% disruption, a 50% disruption, and so on. And these were published, and I think really set alarms off among everyone working in the space. So that's where we were in 2020, kind of wondering how deep would the impact be. And now we actually have some data. And when Carol reached out to me, we didn't have these data, so we do have them now. And I'm going to start with the conclusions first before I show you a bunch more data, because I think they're important. What we now know is that for the most part, treatment continuity was not only maintained, but the number of people on treatment actually increased throughout the pandemic, which is kind of amazing. Also, we do know that, on the other hand, many prevention interventions were interrupted. So that's where it seems that the biggest impact has been, not as much on the treatment side, not really on the treatment side. There's been a little bit on treatment, and I'll show one slide on that. But it really is on the constellation of prevention services. So how did this happen? Well, much of this is due to very quick pivots and accelerated adoption of innovations by both the Global Fund and PEPFAR. It's important to understand their role in this, because between the two, they are providing almost all external assistance for HIV in low and middle income countries. So what they do actually can make or break the response. And many of the countries in which both operate or provide services or support were really struggling with lockdowns, as we all were, with not being able to, their own domestic budgets being shrunk as well. So really it was the Global Fund and PEPFAR that had to figure out quickly what to do. In addition, the U.S. Congress provided emergency funding to both entities to respond to COVID-19. But the other thing, and this will, as I said, I'm starting with the conclusions, the future of this already what seems to be a success in managing this crisis for the most part will depend so much on COVID-19 vaccine rollout and potentially additional funding, which may or may not come. So here's some data. The WHO has been doing a survey of different countries, asking health leaders in countries what kinds of service disruptions they have had. This is an ongoing effort. This was the second, I believe, of the two that they've done so far. They asked about a whole range of services, and so many things have been disrupted, essential services, and they actually did find very high levels of reported disruption. And now these are aggregate. We don't know what they translated to, but this was data that was provided through a survey to WHO. You can see that there was a little bit of reporting on continuation of ARVs being interrupted, and you might remember one of the things that happened early on is that because of the supply chain disruptions and what was happening, particularly in India, some of the generic ARVs could not be sent. And there was real concern that that was going to cause a bottleneck that could actually affect lives. It did get resolved relatively quickly, but that was, I think, partially why we see some reporting of disruptions. But the big impacts reported were on the prevention side. The Global Fund actually just came out with data on 2020, and again, these just came out in September, so they're new. And they reported some good and some bad. On the good side, as I mentioned, the Global Fund saw an increase in the number of people on treatment in 2020 during COVID. Again, quite amazing. But for the first time since the Global Fund has been operating, which it started operating in 2002, 2003, a drop in the share receiving these other critical prevention services. So PMTC, HIV prevention, testing, and voluntary medical male circumcision. Not a surprise. People were in lockdown. People couldn't leave their homes. People couldn't go to test sites. Now, I think I should have said this with the modeling, but one of the, we don't know yet what the impact of this will be on infection rates. We just don't know. Because on the one hand, there's been less access to critical services that we know can prevent new infections. On the other hand, some of the behaviors and risk situations that people might have found themselves were probably minimized because people were isolated and in lockdown. How that all plays out, we don't know, but it's just, it's something that we'll probably learn more about in the next year or two. But now I'm gonna turn to a number of slides from PEPFAR, because PEPFAR, the US Global President's Emergency Program for why am I forgetting the acronym of the program that I've helped kind of a little bit get off the ground, has quarterly data, which is very unusual. Most programs don't have quarterly data, and so we actually now have data from PEPFAR through the third quarter of 2021. And again, these data are recent, so this is what we know from PEPFAR. This is the number of people on antiretroviral treatments, and as with the Global Fund, the number has gone up. It didn't even seem to take any kind of pause or hit during COVID, during the biggest moments of COVID. So that's kind of, again, an amazing story. What PEPFAR has said, the one area where they did have a dip, and they've now have basically recouped those numbers, is the starting people on ARVs. As you can imagine, that was when there was a little bit of the supply chain issue. Their doctors weren't available, people were in lockdown, so that was in the beginning there. But that seems to have mostly resolved itself. However, some of the other areas which are rebounding, this is where we see the dip. The third quarter of 2020 is particularly the time where you would expect the biggest impact, and that's where we see it. Testing numbers went down, the number of voluntary medical male circumcision procedures. It's the last bar because that's for a full year. Those went down very dramatically and actually are now back at levels from several years ago. PEPFAR reports that they believe those will start to go up again, but that definitely is an area to watch. This is prevention and prep through the DREAMS program, which is the program that PEPFAR started in 15 countries to address risk among adolescent girls and young women. So there was interruption of both prevention and a little bit on prep in those countries, although that has rebounded. So what did PEPFAR do? And what did the Global Fund do? What were some of the specific things that they did? Because I think this is something we need to know and we can learn from, but also it shows how resilient some of the programs that we all have been involved in are. First of all, one of the things PEPFAR did from the get-go was start to provide COVID-19 guidance to the field. I think bi-weekly initially, and maybe still, sending out information to all of the programs in country with guidance about how to adjust given the pandemic, the COVID pandemic. Everything from the need to socially distance and take care of healthcare personnel. That was a big principle put in place early on, but as well as the need to innovate and to push out, frankly, adaptations that the program had been wanting to implement on a much more wide-scale basis, but hadn't yet gotten that been able to jumpstart it. And one was multi-month dispensing. PEPFAR had started down the path of wanting to move towards multi-month dispensing for people, particularly for ARVs, but I think they're thinking more generally. But that had it was very minimal. Well, once COVID hit, that became a huge push, and they moved to 3- and 6-month multi-month dispensing, which was I think, a big reason why continuity and increase was maintained. They decentralized drug delivery, so we're able to push out delivery of drugs to people where they were or too close to where they were. So that was another way that they were able to get medications to individuals. As we all have been doing, PEPFAR also used virtual platforms to reach people. And I think this is really important. We're still learning more about this, but has used the many investments in PEPFAR that the US government has made for laboratories and health system strengthening and healthcare workers to leverage for the broader COVID response. So keeping things going more in a bigger way during this. We just learned from a meeting last week that Carol and I were at that PEPFAR is actually piloting delivering COVID-19 vaccines in a couple of countries to people living with HIV, which I think is an incredible step and something that I think we should be watching, because that may be what will make a difference for people with HIV in those countries who have very little, if at all, access to COVID vaccination. And as I mentioned earlier, the US Congress provided emergency funding to PEPFAR specifically, like it has to many programs, particularly in the US, but provided $250 million in emergency funding to the program in recognition of the need to, the PEPFAR needs to be backfilled in a way for having to divert resources, as everybody has, from using its platform to help with the broader COVID response, and from really needing to mitigate the impact on HIV. So those funds were provided for fiscal year 2021. PEPFAR has reported that those are essentially spoken for at this point. So it's an open question as to whether more will be provided. What did the Global Fund do? I think some similar things. The Global Fund is a little different than PEPFAR in that where PEPFAR actually runs and has programs on the ground in many countries. The Global Fund is a financing mechanism, first and foremost. It provides funding and works with PEPFAR, and the US is the largest supporter of the Global Fund. But what the Global Fund did really early on as well is immediately launched a way to finance the COVID response to mitigate the impact on HIV. Created something called the COVID response mechanism, which it was able to reallocate some funding and then raised new funds, particularly from the US and some other donors, to provide to the countries where it already had HIV, TB, and malaria programs, to allow those, the finance programs there to survive, to provide mitigation efforts, oxygen, lab support, et cetera, purchasing tests and treatments, and also has provided grant flexibilities, similar to what PEPFAR did as well. And it's ongoing. This is an ongoing work that the Global Fund is doing. It also received emergency funding from the US Congress and others, but the bulk of what the Global Fund received was from the US, which is $3.5 billion to address in about 150 countries where the Global Fund works to address the impacts of COVID. So I think the story here is quick adaptations, pivoting and mitigating impact, but also emergency support. It has to go hand in hand. So with that, that is sort of where we've come to and what we know as of today. What can we think about going forward? These are just some recent data on what we know about COVID-19 vaccination and mitigation measures, and I really think this is going to make or break the future for HIV and for really the global COVID response, because if we do not have control of COVID, we're going to see endless cycles of impact, probably here and certainly in the countries that have no access to vaccination. And that is going to impact the HIV response, as well as many other efforts. Interestingly, and probably the first time I've ever seen this, there has been a very direct link drawn by the leading financial institutions in the world between economic recovery and vaccination for COVID. So these are quotes from the IMF, the Federal Reserve, and Janet Yellen that basically say, we will not have recovery without vaccination. And any kind of positive results we're seeing in the economy are very fluid and precarious, frankly. As Secretary Yellen just said a couple of days ago, when the really positive job numbers came out, there's an alternate present where our economy is still stagnating, where there's millions who cannot find work. And in large part, this has been avoided by smart policy and action. She would say that, she is the secretary. The American Rescue Plan, but also an immunization campaign that's vaccinated 193 million Americans. So recognition that the economic recovery is dependent on vaccination and on the course of the pandemic. But this should be not a surprise, vaccine access rollout is very unequal and inequitable throughout the world. And so you can see the dark green areas are where vaccination is highest, and the areas with very little colored in is where there's virtually no vaccination happening at all, or very, very little. We've been here before, we've seen it with HIV. We're now in a pandemic that spreads differently and quickly and has variants. So this is very dramatic implications for all of us. Vaccination progress varies greatly by country income. So here you can see, based on how you categorize countries, so high-income countries like the United States, right as of November 6th, when I pulled these data down, 65% of the population was fully vaccinated. Upper middle income countries, that's a good story, 61%. Once you get down to lower middle income, 22%. Low income countries, 2%. 2% compared to 65%. That's the challenge that we face. And you can see that a little bit here when you look by region. Just look down at the bottom, Sub-Saharan Africa, 4% have been fully vaccinated. This is, I think, the challenge for HIV. It's the challenge globally that we all face. Here's another picture of the problem. Rich countries have given out more boosters in 3 months than poor countries have given total doses all year. This is how do we tackle this? Hopefully you have some good ideas, but this is the challenge of this century for sure. And from some work we've done, and others have looked at this too, at the current pace of global vaccination, if something doesn't change, the disparity is actually going to grow. And there is no way that low-income countries in particular can meet any of the goals that were set by the WHO, by the Biden administration, and frankly, what is needed to make this pandemic end. One of the questions that comes up a lot is supply. What are the reasons that we're in this predicament? And some say supply is not a problem at all. I think supply isn't the main constraint. And this just shows you that there's a lot of doses that have been purchased, actually, enough probably to vaccinate most adults in the world, at least through the initial course. However, the distribution of these vaccines is the problem. In addition, some of these purchases are dependent on things that happen with vaccines that do not yet have authorization or have not yet been approved. So this is tenuous. If Novavax, for example, doesn't get WHO emergency use authorization, then that will be a chunk of the supply. If J&J eventually needs to be a 2-dose vaccination course, which it seems to have become in the United States, that will mean the supply is not going to go as far. And you can just play out the scenarios. Here's another look. An organization came out with a forecast saying there's a lot of potential ability for manufacturers to scale up supply in the future, but again, I think some of this may not be realized. And one of the challenges too is how quickly will this happen? We know that speed is of the essence here. This is a snapshot of current donations. So one of the ways to address this challenge has been donating excess doses from high-income countries in particular to countries that don't have as much access, or to COVAX, which is the international facility that was set up to help address this problem. And you can see a couple of things here. In total, there have been a little over 2 billion doses pledged, donated. That's a good thing. It's certainly nowhere near the need of how many people live in the world who did not have access. And you can see also that the US has provided more than half of those doses. The second thing, and it's hard to see from here, is that most of those doses have not been actually delivered for any of these by any of these countries. There's lots of reasons, not necessarily the fault of the entity donating, but for the US, for example, the US has, as I said, has pledged 1.1 billion doses. Most of those doses are Pfizer. Pfizer is not the easiest of the vaccines to quickly deploy to the field. And so part of the challenge is delivery, on the delivery side. Other vaccines from some other countries are ones that they have pledged, but may not have been, they might not have optioned them yet. So these are likely to be available, but they're not all delivered. And then there's delivery challenges that have come into play. And it's not just vaccination. I think vaccination is probably the biggest challenge here, but if you look at COVID testing, we all know how challenging testing has been in the United States for COVID. It's really worse in other countries, as particularly low-income countries. Much less testing is happening, which feeds into what we know about the impact and all of those things. And oxygen. This is an estimate of daily medical oxygen needs in low and middle income countries. It's very severe. So basic things that we have at least had here during this horrible crisis are just lacking completely. And so how the world deals with it, here's an estimate of funding needed for the global COVID response. This is an estimate put out by ACT-A, the ACT Accelerator, which is the global WHO response mechanism that was set up. Whether these are the right numbers, I don't know, but it's probably in this order. What they say is something like $43 billion are needed still. I mean, it's hard to understand where that's going to come from, but that's probably as good an estimate. Maybe it's higher, maybe it's a little lower, but it's of that magnitude to vaccinate the world. And that's not just to get the vaccines, it's to deliver the vaccines. It's to do other mitigation measures, diagnostics, therapeutics, health system support. This is a massive undertaking. And whether it goes back to whether PEPFAR and the Global Fund can weather that storm, just the two of them is a big unknown. So I thought it would be important, though, to say that in addition to the things that we know that PEPFAR and the Global Fund, and I should have said this from the outset, Ryan White in the United States and many programs that I'm sure you all are working in have done to mitigate the impact on clients. That is a story that I really think we have to keep telling. There are lots of lessons from HIV that I think we all saw right away for COVID, and I thought it would be important to highlight them here. One is the role of communities. Obviously, we know from the HIV response that you cannot have an adequate response if communities aren't helping to drive that response, aren't part of that response, aren't involved in implementing, monitoring, and all of the throughout the chain of implementation. That has been a hard lesson to learn in COVID, and it's still ongoing in many places where communities have not been included in what is happening. We also know, and I understand you had a session on this too, that misinformation and disinformation, we know that from HIV. We've lived through that, and we know how harmful that can be. And fortunately, in the HIV context, most, not all, but most of what we experienced in the 80s and 90s has dissipated. It's not all gone, but we know how deadly that is. Science, the role of science, the importance of science. With that, I mean, none of us were surprised to watch how that played out, but that is another lesson from HIV. Combination interventions, that one intervention, as much as I believe, and I do, that COVID vaccines are really the thing that we have to focus on probably the most, I know COVID vaccines alone are not the answer. I know, we all know that we need other mitigation measures. We need to address the full challenges that people face in their lives, which might prevent them from accessing a vaccine or prevent them from being able to social distance, maybe have forced them to continue working in unsafe environments. All of those things are going to be part of the response. We know that from HIV intimately. And related to that is social determinants. If that's one thing that I see very little positives have come out of COVID-19, but that experience, but I think there's much more awareness because of it, of the role that social determinants play in both putting people at risk as well as complicating their ability to get the services that they need. Human rights. If we don't put human rights at the center and understand that the basic rights that people need, whether we think of them as housing or as health, as access, to be treated fairly, regardless of who they are, what they look like, who they love, we know this from HIV. Stigma, there's COVID-19 stigma, and that has not just played out in the COVID-19 pandemic, but it's certainly played out in how people have been treated for not being able to adopt mitigation measures. Equity, we know too that it's not just about providing people with an equal number of services, it's making sure that they can get those services. So what does this all mean for our global targets? There are global targets that UNAIDS, the UN special agency that oversees the global HIV response from a sort of policy perspective and guidelines perspective, has set targets. These were set before COVID, and they frankly were very ambitious. But this is some recent modeling that was done to say, well, what do we know about our progress towards these goals? And I'll just point out a couple of things. The goal is the bottom line on an orange. The goal is to get to roughly 200,000 new infections in 2030. Already you see from the historical average, we weren't doing very well. It was pretty likely that we probably wouldn't get to this goal. There is a scenario where we do better, that's the green scenario, but the red scenario is taking into account the worst impacts of COVID. So we do know that this pandemic is setting us back on our HIV response, even if PEPFAR and the Global Fund and Ryan White and all of the work that we're doing has been resilient and has been innovative and has been quick. So I'll leave you with these thoughts about it, and then I'd love to get questions or have a dialogue with you. What I don't know the answer to is how long is this going to go on, and how deep or indelible will the impact be? If certain countries, certain regions, certain populations have a permanent impact on their livelihoods because of COVID, that's going to have a permanent impact, I think, on the HIV response. There's a big policy question about whether there will be additional emergency funding provided to either PEPFAR or the Global Fund by the US, and then for the Global Fund from other donors, and what their future role will be. We could talk about that if you want, but there's a lot of discussion going on about how much those two efforts should play a role in not just helping to end COVID, but future pandemic preparedness and what that might mean for the HIV response. And so the bottom line is, how resilient will the global HIV response be? I think we've seen incredible resilience. I hope we continue to, but I think it's a bit of a precarious situation. And so with that, I am going to stop, and we have some time. If anyone has any questions. If not, I'm happy to give you recommendations for like where to go in DC or other things.
Jen, thank you for a great talk. I was wondering if you could address the phenomenon of long COVID and what some of the implications of that are.
For HIV, the HIV response specifically?
Either one, COVID and HIV.
Yeah, so long COVID, which people who aren't dying from COVID, but are suffering from long-term effects of the disease. We're still learning a lot about it, so that's one of the issues, is why certain people are having long COVID, others are not, and then what that might mean for their larger health needs. It really complicates health needs, and it's, I think at least in the US, one of the challenges that we are starting to see is how that's dealt with in the healthcare system in terms of an insurance model, in terms of access, in terms of recognizing those symptoms and addressing them. I think in the global context, it's gonna be much more complicated because we're talking about, I think it could present a real problem to programs like PEPFAR, which have, even though they, I think, have taken a more expansive view to their mission to try to maintain the HIV response, can't do everything. And so if long COVID becomes a phenomenon that is becoming more prevalent in countries that are already seeing a potential impact, that could really strain systems. I don't have an answer for that, but I think it's a great question and something we should all be paying attention to. And I do not believe it has been explicitly addressed in the global context in the way it probably needs to be. Thank you.
The 2% vaccine rate in other countries, and I'm thinking particularly about South Africa, where some of us have worked, some of us are still working, and just how heartbreaking that is. I'm on I hate to say this, but a Facebook page called Nurses Who Care, and it's all nurses from South Africa. And the rate of death, illness and death amongst nurses and care providers in South Africa is stunning. It's just stunning. And so I'm wondering, and so that breaks my heart every day when I see this, continual roll of sisters who have passed. But I'm wondering if, we remember back to when ARVs became available and governments wouldn't accept them, and in particular thinking of Mbeki in South Africa. Do you have any sense of vaccine hesitancy on the part of governments in terms of being recipients of donated vaccine and scale-up efforts? Hopefully?
I think, good question. I think in general, no, there has not been that same, the governments themselves have not been particularly hesitant. There was one example where there was some hesitancy, but I think that was overcome. But I think in general, governments are not the barrier to I think most governments want the vaccine. There's certainly vaccine hesitancy in every country, though. Though I think not to the extent that we've seen it in our country. I think right now, as you probably have seen from that Facebook page, people just wish they could get vaccinated and are really struggling, not understanding why this is happening. Yeah, but it's a good question. I think that's it's a good question, and it's also, I think, a positive that governments really do want to be able to provide vaccines to their populations. In fact, the African Union has formed its own vaccine alliance to secure vaccine purchase and donations for the African Union itself. Even though there's international mechanisms to do that, they've done that as well. So that's for all of Africa, and I think it speaks to, and Latin America has done a similar thing. I think it speaks to the real urgent desire to vaccinate their population. Yeah, so good question. So one of the issues I didn't address was, and we know this from HIV, is part of the challenge here is if vaccines are not readily available and being able to be cheaply or freely provided, that we know is a big barrier. There's a couple different issues. One is what is trying to be done is that through the donations and through the international COVAX facility, that vaccines are being provided free or at very, very low cost to countries that are below a certain economic level. So that's one. But two is this issue of sharing technology. And that's really, that's been a difficult one. Moderna, for example, which is a vaccine, the vaccine has been largely funded by the US government. There's been an issue with, will Moderna share technology? Moderna has come forward and said they're going to be they're moving in that direction. But I think that's an area to watch. I guess the issue is if they were to do that tomorrow, would that lead to a excess supply immediately? I don't know if that's like fixed overnight, but it's certainly one, and it's actually resulting in changes in manufacturing around the world, because it's very much recognized right now that one of the challenges here is that manufacturing is not taking place where vaccines are needed. And so how can regional vaccination hubs like in Africa be built up so that more localized production could happen, whether it's for COVID or future pandemics. But once again, the manufacturers are not, it's a mixed bag, I would say. Good question. And then the other thing I didn't talk as much about, but delivery is, I think, going to be supply is one issue, but I really think delivery is going to be such a huge, huge challenge. I think, programs like PEPFAR are well positioned to help with that, at least for people with HIV or people at risk. But there's been such a race to get vaccines that the delivery part, particularly in low-income countries, has really lagged behind. And so I think we're going to be hearing about that for the next year, 2 years, yeah.
You talked about the boosters and the huge numbers of boosters compared to worldwide vaccine distribution. But if I forego my booster, I don't know how to get it to Zambia or to South Africa. Like, how do we do that, and how do we say that we agree it's not fair?
Yeah, it's a good question. So some of the supply forecasts and things that I showed you don't take into account. I mean, no one's talking about boosters much internationally other than in high-income countries. And so what do? Should we forego our boosters? I think that it's a false dichotomy. It's not going to work to think of it that way. I think the way to think about it is that there is enough supply or manufacturing capacity if it is mobilized and deployed appropriately and distributed in appropriate, equitably, we can achieve this. But it's a tough question. I think that's where we get into politics. So, for example, President Biden, when he took office, he made it very clear, yes, we are going to help the world once we have enough supply. Some people disagreed with that. Others thought, what else could he have done politically? The good news is the U.S. does have enough supply for all of us, for boosters, for additional doses, for kids, and has donated $1.1 billion and about $4 billion for vaccines, and actually could donate more. So it's not the other thing I would say is we just released I should have shown this, we just released some survey data. One of the things we do at KFF is we do surveys of the US public on lots of different health issues, including COVID. And we just asked a few questions on views about the US role in global vaccination efforts and providing vaccines to countries that need them. And what we found was that when you told people that the reason that the US had enough supply at home, that vaccinating people in other parts of the world helps achieve immunity for the world and can help end the pandemic, and vaccinating people throughout the world can protect against variants, their support went up significantly. And those are facts, so that's a good thing. So I think there's ways to do this. There could be ways to get political support, but it is a really tough question. And frankly, one of the challenges too is, I showed you the graph of how much the US has donated. It's other countries that haven't really stepped forward as much.
Hi, Jen. Barb Cardell with PWN. So good to see you. I was really inspired by the innovation with PEPFAR, especially about the 3-month and 6-month fills. Are they continuing to have that available? Or is that something that's going to change as quote-unquote COVID is decreasing?
Very good question. It is not going to change. The good news is that the Office of the Global AIDS Coordinator, PEPFAR itself, had been wanting to implement that before COVID as a way to help people. And now it is, I think, a permanent part of how they're going to approach the program, which is great. And it makes a huge difference. And they're actually seeing its uptake is really happening. And Ryan White has frankly done the same thing.
Yeah. So what's interesting is, I mean, I sit on the Colorado ADAP committee.
Yeah.
And it's very interesting because we came up with some remarkable innovations around COVID in our state. And it was electronic signatures for certification, and it was a 30-day fill, and it was telehealth and so much else that really was able to expand access. We were mailing HIV tests to people as well. I mean, so we were trying to come up with all these really innovative approaches, and now we're finding that they're being actually restricted. So I'm curious about advocacy, because again, PEPFAR leads, and with NHAS and so much else. How do we get the United States to follow along with these innovations? Because they really are opportunities for us to follow the science and to make some really significant changes.
That is a great question. So HRSA, that oversees the Ryan White program, or that administers the Ryan White program, has been quite supportive of those kind of innovations. So I think the main question is, so it sounds like that's a local decision to end some of those. And so if that's the case, part of the sort of leverage here is guidance from HRSA, I think. Yeah. And guidance from HRSA is not, honestly, is not going to be able to be as strong as guidance from PEPFAR to its programs, because states have a lot of flexibility in what they do. But I think that's the biggest leverage. That may already be happening to some extent, and I know HRSA is trying to promote flexibility. Yeah. But one piece of information you can use is PEPFAR is doing it and has implemented it as a permanent part of its program.
Yeah, I was trying to verify if it was a state decision or if it was at the federal, or a misinterpretation of the federal guidelines, but I haven't heard back, but I'll let you know if I do.
Yeah, and I would guess that it is a state decision. There might be some specific things that were funded through emergency support under Ryan White that might not be able to continue. I would imagine that would not be important in innovations like that. And it's something I can actually look into as well. So I think that's probably local decisions.
Yeah, thank you.
Sure.
Hi, Jen. Thank you. Christian Legerman from DC Health. My question is more of the vaccine hesitancy, especially in the low-income countries you're talking about. Is there anything going on, some kind of education? Because I know I've tried to communicate with people and they don't even want to listen. So the resistance is so high. So I'm not sure, is there anything happening by WHO or PEPFAR on that end for COVID vaccine? Thank you.
Yes, probably not enough. The WHO, the African Union, many of the big mechanisms that have mobilized to try to get vaccines to all countries and to put in delivery systems are addressing hesitancy. It's very challenging to do so, as we know in our country. So I think the vaccine hesitancy varies by country. It's not, some countries there's going to be more of an issue than others. It'll be this is where I would love to do, if PEPFAR would do this kind of pilot study, since PEPFAR has such a footprint in delivering HIV medications. I wonder if delivery and promotion of vaccination through PEPFAR would achieve better results, because there's sort of already an understanding of the life-saving aspect of those medications. So I'm sure. I wonder. We should talk to PEPFAR about doing that. But it's a good question, and the answer is yes. But I think it's going to be an uphill challenge.
I think I know the answer to this question, but I just wanted to ask, in any of the models, as I know that many places, even in the United States, Louisiana, have been hit by natural disasters over the last year and a half. Horrific. I mean, all over the globe, on top of COVID and HIV incidents. So I don't know if that has been modeled in as another factor, because I think, well, we know it's going to continue. And so if we're hoping that things are going to start getting a little bit better, I don't know if anybody's brought that factor in or not.
Good question. None of the models are including that I have seen, but one of the things that has been raised in different settings is if any other shock comes into a system, whether that's a natural disaster, a famine that's caused by some, not COVID related, but is happening, war, conflict, or let's hope not, another pathogen, new pathogen, all of this it's fragile. And so it would completely change what we're talking about. I wanted to mention another innovation that is domestic in case people don't know about it, because I was reminded with thinking about ADAP. HRSA just announced in the last couple of weeks 2 changes one was a change and one was sort of a firm support of a policy that I think one is very COVID specific, and it's really important. For those who get funded by Ryan White or work in Ryan White clinics, you know that recertification has been a challenge. Getting electronic signatures is a great thing, but having to recertify people every 6 months or whatever it is a real challenge. HRSA has now said you do not have to do that and has changed it. Yeah, it's a big thing. Yay. HRSA has also said affirmatively, which has always been the policy but has not been clearly articulated out, in big letters, that you are eligible for Ryan White support regardless of your citizenship, your immigration status, or anything related to that. So 2 things that I think are really important that were just announced. And the first one on the recertification, not necessarily COVID specific, but I'm sure COVID had a part in showing that that barrier and burden is really problematic for a lot of people. So, any other questions? There's a few more minutes.
I'm Smita, I'm from Iowa. So I was born and raised in Nepal, and I came here when I was 18 years old, and I always, United States is a kind of like a powerful, everybody know everything kind of, but COVID kind of reflected me like, wow, like our knowledge about public health, our knowledge about prevention and all that. During the vaccination itself, my 83-year-old grandmother back in Nepal, she's on the long line to get the vaccine on hot summer. And here we are handing out $100 vouchers, we're handing out state fair tickets and all that, and people are still hesitant to get the vaccine. So I know COVID had given some kind of education about prevention, education about public health and all that, but I have a fear that education or that information gonna go away or it's gonna fade away. So as a upper level or the government and all that, what are the steps that's gonna happen or that's gonna be promised that people are gonna get more knowledge about their own health, knowledge about the public health and knowledge about the prevention and how important it is to have a public health and respect that. Thank you.
How much time do you have? 2 minutes, okay, in 2 minutes. Well, one thing I was gonna say, right before COVID, there was an analysis that came out that looked at readiness of countries to respond to a pandemic. And you might imagine we're at the US and the UK and high-income countries were all at the top, like, gonna be have the best responses, they're most able to respond. And what they didn't take into account was politics and culture. And those are very, very hard to affect and change. So I share your concern. One thing that has occurred, and we don't know what the balance is going to be because so many people who never thought about vaccines in their life never really began to understand what immunity means or why their kid might get an immunization or what testing is about. I mean, there's so much more knowledge. So will that counteract the share of people who are trying to undermine that knowledge or don't want to learn from it or having trouble accepting it. I don't know. But there's been also billions of dollars invested in public health now in the US. If it's used wisely, it can begin to I think, some of it's retrofitting, some of it's forward, new work, new progress, change some of this. But I share your concern that, you know, if we have another pandemic, will we live through this again in the same way? There have been some positives that have been learned in the U.S. experience, and you know, some of the things that we've seen with testing now becoming more available in the U.S. and there are ways to make those changes. But I'm with you on that. So, okay. Thank you.